Hello, I'm Linda Borrell, and I'd like to report to you a study of a randomized controlled trial of an ICAP, an Intensive Comprehensive Aphasia Program. And I reported the results of this study at the Nordic Aphasia Conference in Reykjavik in June 2023. I'd like to acknowledge the large team, particularly Jade Dignam and Errol McKinnon there, who provided a lot of assistance for this particular project. This was funded by the National Australian Research Body called the NHMRC and the Wesley Research Institute. ICAPs are growing. They're growing in numbers, and they're evolving into adding all sorts of components to an ICAP. But there's no high-level evidence at the randomized control trial level showing their effectiveness. So the aim of this study was to assess the clinical effectiveness of an ICAP compared to usual care. And our hypothesis was that the language impairment and functioning therapy, or LIFT as we knew it, will have significantly better reported communication and connected speech outcomes than usual care in adults with post-stroke aphasia. We designed a parallel, assessor-blinded, two-arm, stratified, block randomized controlled pragmatic trial. So it's easier to understand that those words when you see what the methods were actually in real life. So we recruited 10 hospital speech pathology departments who referred potential people with aphasia. And they were referred to screening, and we screened with the CAT cognitive screen, and they had to be able to forego other speech therapy while they were in the LIFT side of the trial, and they were to be discharged to the local area because they might have been randomized to one of our LIFTs. They were excluded for the usual reasons, if they had a coexisting neurological or mental health condition, severe apraxia of speech or a dysarthria, or a global aphasia, so they couldn't complete the assessments. So in reality, speech pathologists referred people with aphasia. They knew what the selection criteria were, and once they were screened by our research speech pathologist, we waited until we had two of the same level. So two people with aphasia, for example, who had a moderate severe aphasia, or two people with aphasia who had mild aphasia. And so then they were randomly allocated by our statistician to either the LIFT program or to usual care. And so over the course of the study, we had 9 programs, 9 LIFTs, and the time post-stroke of all of the participants was between 4 and 18 months post-stroke, so sort of the usual rehabilitation sort of period. We assessed them before, after, and at 3 months post follow-up. The outcome measures that we used, the primary outcome measures were the discourse, in particular the content information units, and the assessment for living with aphasia, which is an aphasia-friendly, self-reported ability across all of the ICF domains. The secondary outcome measures that we used were the CAT, the Philadelphia Naming Test, the Assessment for Quality of Life, the SETI, and the Bacchus Caregiver Outcomes Scale. And the backus is given to the family member about their own caregiving of the person with aphasia, whereas the SETI, which is also given to the spouse or the family member, rates the functional communication abilities of the person with aphasia. The aphasia lift itself was scheduled for 3 days a week over 8 weeks, 49 hours in total. And we started with asking the participants, what their goals were, and then we tailored the therapy to meet their goals. So there was 2 weeks of impairment therapy, 2 hours of impairment therapy a week, the same 2 hours of functional therapy a week. There was 1 hour of group therapy a week, and there was 2 hours of computer therapy. So, and we just used all of the evidence-based therapies that were available that were able to meet the goals, so to be the therapy that might meet the goals of the participants with aphasia. We also had a challenge goal, so that on the last day it was sort of like a graduation where we invited family members and friends and perhaps speech pathologists who had been involved in their care or other health professionals, and the participants with aphasia demonstrated a skill or overcame a challenge that they had been working on during the 49 hours of the LIFT program. So the group results, but first of all, we just want to see what the consort chart tells us, is we had 269 patients who were approached. 99 of those declined. And so they declined because of things like other medical issues or priorities at that time. They weren't interested in speech therapy or intensive therapy in particular. The aphasia was too mild or not considered a problem at that time. They preferred to continue with their usual care. There was some issues around transport as well. And then we had 95 of them were excluded by the referring speech pathologist prior to the actual screening by the referring speech pathologist. And the majority of those, the reasons why that was because they had comorbidities, or that they were being discharged outside our partner sites, or that they were already sort of past 13 months post-stroke. So we had, in the end, 75 participants who were assessed for eligibility, and of those, 52 were randomized. And 18, the sort of process was that there were 18 excluded because they didn't meet the inclusion criteria, and 5 declined once they sort of heard more about the project. The randomization process randomized 26 participants to LIFT and 26 participants to usual care. 3 of the participants withdrew in the LIFT program, and 5 withdrew in the usual care side of the arm of the study. When we got to the analysis stage, we found that 1 participant in each group was included for the wrong reasons. So that this one was too mild, and another one was excluded because they weren't actually screened in the first place. So we had 22 who were analysed in the LIFT and 20 in the usual care group. What was usual care? The majority of participants in the usual care group had no aphasia therapy at all. And there were 7 participants who were having aphasia therapy, and the mean number of hours that they received was 13.76 hours of therapy. Our linear mixed modelling across all the outcome measures at both post-therapy and 3 months follow-up. So in the primary outcome measures, if you remember, we were hoping to get a significant change on content information units between the LIFT program and usual care. But that didn't happen. However, there was a significant result for the total ALA between pre and post therapy. The aphasia domain of the ALA, there were significant results at both post therapy and the 3-month follow-up. No significant results for the participation domain. The environmental domain was significant, at post therapy, but the personal domain, there was no significant differences. Sadly, there were no significant differences on the CAT, on the Philadelphia naming test, on the SETI or the AQOL-4D. However, there was a significant difference at 3 months for the Backus caregiver outcome scale. So that's sort of saying that the family members are reporting less caregiver burden after the LIFT program. Looking at individual responses, we looked at the minimal detectable change for the ALA, and it was really quite large at 24. And we found that there were 3 in the LIFT group who responded positively more than the MDC. But in the usual care group, there was 1 participant who deteriorated more than the MDC. In the other significant result in the Backus caregiver outcome scale, there were 3 family members who had greater than the minimal detectable change. In many respects, we felt that was a disappointing result. We would have preferred more responders to the LIFT, but there is some promising results there. So LIFT was significantly better on patient and family reported outcome measures. At the post-therapy stage, there was the assessment for living with aphasia, the total score, and that was also for the aphasia domain and the environmental domain. At 3 months follow-up, the ALA, aphasia domain, was still significantly better from the LIFT participants to the usual care participants. So people with aphasia are reporting that their aphasia is much better even at 3 months post-LIFT compared to usual care. In addition, the Backus caregiver outcome scale is saying that the family members are reporting significant change at 3 months post-stroke, less caregiver burden. But also, if you saw from the consort flowchart that there were high rates of exclusion of participants and also declines for participation, but there was low attrition. So we had 42% excluded from the study and 63% of eligible participants declined to participate in the study. So that is probably going to be different when it's not a study. Some people don't want to participate in research, and certainly the testing involved could be a deterrent. Also, I think that the usual caseload, it reflects the usual caseload of people with aphasia in that they often do have comorbidities as well. But ICAPs or intensive therapies have been often criticised because they have had high dropout or attrition. But we didn't find that. Once people were in the program, only 12% of the LIFT participants withdrew once the LIFT began. So in conclusion, I think we can say that if people with aphasia are suitable and willing to complete an ICAP, outcomes were better than usual care on patient and family reported outcome measures. We can do better. We would like better, more significant improvement on measures such as the CAT or connected speech. But I think that sometimes maybe they always don't capture the improvements in language and communication that have occurred in the LIFT. But certainly the people with aphasia are reporting significant improvements, and family members are too. To overcome some of the issues about suitability and willingness to undertake an ICAP, I looked at the reasons for declining and the reasons for not being suitable. And if we were to overcome those barriers, we would do things like if we were offering ICAPs in routine clinical care, we would possibly be offering the ICAP at different stages post-aphasia. For example, that is when they were ready. We had a period of recruitment that was between 4 and 18 months. Well, the recruitment was 13 months. So to some extent, people perhaps were not really ready even in those periods. I think that the evidence, we've been going blind into our recruitment because we didn't know whether ICAPs were better than usual care. But now we can show the evidence in both written and verbal format to people with aphasia and their family members to say, well, if you do this intensive comprehensive aphasia program, you should get these better outcomes than usual care. Also, I think providing transport options for those who need it would help considerably. Offering an ICAP by telerehabilitation is certainly something that some researchers in Australia have been working on. And if we could implement ICAPs more widely, there might be ICAPs closer to people. And in fact, really, I think if we say that ICAPs are really best practice, that is what aphasia therapy should be, then perhaps we just don't call them ICAPs, that this is what aphasia therapy should be in all centres. But also, I think we could consider adding therapies for the comorbidities, for sort of things like mental health issues, for cognitive decline as well. So we may not get the same results when we add those participants in, but at least they would be given the opportunity to improve and to get the therapy for those comorbidities. So I think these results are very promising. We can make the ICAPs much better by trying to sort of improve, for example, the CAT scores and naming scores and connected speech scores. But I think this gives us preliminary evidence to say that the ICAPs are effective. Thank you.